And his seminar this Friday is titled Wearable Informatics, so leveraging human-computer interfaces to improve healthcare. So the idea is looking at how we can use technology that's being worn to extract information on personalized medicine and even ways to kind of predict disease. So it's kind of a interesting topic. It's 10 a.m. to 11 a.m. this Friday in this room. And I really encourage you to apply. I really encourage you to come, okay, to attend. I think you'll learn something from it, especially if you're interested in this particular space. So this is part of our Center for Bioengineering Innovation lecture series, and I'll be telling you more about it. We've already had someone present this semester from the university on intellectual property. This is our second speaker. We have a third speaker lined up in November, and I'll tell you about it as it gets closer. And that's somebody external from the University of Arizona. And he's going to talk about some glaucoma research. Okay, so it's kind of an interesting lecture series that we have going, and I'm trying to encourage you guys to attend. All right.
Once a month?
It's approximately once a month, about every 6 weeks. So if you look at the syllabus, we're post-exam 1. So today, being the 14th, we're going to be talking about hypersensitivity, autoimmune diseases, and we'll get into immunodeficiencies, both primary and secondary. And you knew that because you did the quiz and you probably saw that that's what's on cue. So we're right on schedule. We've got next week we have the nervous system diseases, and I will remind you next week. But next week there's 2 pre-quizzes in your folder, and then there's 2 post-quizzes. And the reason for that is there's a lot of content within the nervous system, and we only have time in the semester to do 1 lecture because we actually have an extra week off, which is Veterans Day happens to fall on a Wednesday this semester. And so we don't have class Veterans Day, which is the 11th of November. And so I made the decision, instead of that week assigning you homework, even though you don't have school on Veterans Day, and having an online lecture, I would just kind of cram things in 1 week, do it succinctly, give you that week off, but we're going to have kind of twice the number of quizzes next week. Okay? So that was the trade-off that I kind of decided. But that does mean that you have Veterans Week essentially off, because there's no pre-quiz or post-quiz. And these things are highlighted on your syllabus, so it's pretty obvious. Like, we had an online YouTube lecture. Next week you've got double quizzes. And then we have another online YouTube lecture, which is the Wednesday before Thanksgiving. Remember that? So we're sticking to the schedule, nothing really surprising, but there are some little nuances that I want to remind you of. Okay, before we get into the material, so what do rotten eggs, rotten fruit, and spoiled milk equal? Rotten eggs, rotten fruit, and spoiled milk. Groceries. What stays in a corner but travels around the world? Stays in a corner but travels around the world. A stamp. Who said it? Nice, in the back. From the nosebleeds. Nicely done. Cubs fan? No, I'm just kidding. Some of you are like, what does that have to do with it? We're having an incredible season, in case you haven't heard about it. Okay. I'm not a Cubs fan. I was just watching the news this morning. I was like, oh wow, good for them. They actually won. I think 1908, right? Party like it's 1908. I think that's the Chicago slogan, something like that. So, all right. So now we're on topic. We're on task. We're going to be talking about hypersensitivities. So the first thing to say about hypersensitivity, and I think I mentioned this before our exam, but we're back into this material. We talked about how it's a lot of material to go into immunology and try to cover it before the first exam. So I intentionally try to get to a point where it makes sense to stop, and then we do the rest on Unit 2. Does that make sense? But really, this is a continuation of what we talked about before we took Exam 1. And we talked about allergies, and we talked about the different types of responses, and I mentioned hypersensitivity. And now we're going to get into the nitty-gritty of the details. But hypersensitivity is an immune response which is beneficial. An immune response which is beneficial. However, it goes too far or it's too aggressive. And because it's so aggressive, it has deleterious side effects, or side effects that aren't beneficial. So it's a beneficial response, but it's too aggressive, and then it has these side effects, consequences. And that usually means that there's some sort of tissue damage. So if you think about sort of the easiest example of hypersensitivity, take allergies, for example. How many of you have an allergy to something? Okay? Some of you feel like you're allergic to pathology now. I get it. But let's say, what are some of these allergies? Let's shout them out. They don't even have to be yours. Peanuts, bees, cats, shellfish. I have a daughter who's allergic to shellfish. Peanut butter, okay. Nut allergies, penicillin, okay. So these allergies, let's say it's an allergy that's sort of a pollen-based or a cat allergy. So if you have a cat allergy or you're allergic to like olive trees, if you're allergic to pine trees, you're in trouble going to school here. But let's say there's a lot of people from the valley are allergic to olive trees, okay? Or Bermuda grass. We have a Bermuda grass allergy. So if you run on the Bermuda grass field, Bermuda grass is the grass that grows in Phoenix, where it's kind of not really grass, but they call it that. It's usually brown most of the year, and then in the wintertime they put rye over top, and then it looks really nice. And then when it gets warm, it dies, and the Bermuda comes back. So the Bermuda grass has sort of this long, sort of prong-like top, and it releases a tremendous amount of pollen. Well, that pollen gets on your skin, and it causes tissue damage because it causes inflammation. And that inflammatory response is that damage response. Well, we're going to look at other types of hypersensitivities. That one would be classically called a type 1. Any of the ones we just talked about are type 1 hypersensitivity. It's IgE mediated. We talked about IgE before the first exam. And that IgE is antibodies are being produced towards that particular antigen. But hypersensitivities don't just fall into the category of IgE, nor do they just fall in the category of B cells. We have hypersensitivities that are T cell mediated, and we're going to look at that. That's with type 4. Type 4 hypersensitivity is a T cell mediated response, and the example there is going to be transplant organ rejection. Okay? So a patient gets a donor kidney or a donor liver, okay, a donor heart, and there's all sorts of idiosyncrasies around how much time you can transport the heart before it's no longer viable. It has to be on ice. It's usually with cardioplegia solution. But even if it's all successful and you get everything all hooked up correctly, there is likely going to be a rejection by T cells due to those antigens, and that's a type 4, so we'll talk about that. And there's this definitive period of time. It's very short for a heart. It's much longer for like kidneys and livers. But you have to get to it pretty quickly. You can't get a donor from too far away because the transit time won't allow it. But that actually is viability of the tissue. It's not necessarily type 4 hypersensitivity. So there's a sensitization that takes place with all hypersensitivities, and there's 1 through 4. We talked about the bookends. We'll talk about 2 and 3 and the uniquenesses here in a moment. So the sensitization is the first time the individual is sensitized and they see it. The first time is when they're first stung by a bee. There's a pretty aggressive response, right? And a lot of times maybe the kid gets taken to the urgent care and they say, you know what? You're probably allergic to bees. And so we should really not have you get stung again. This happened to my daughter who's allergic to shellfish. So like every Valentine's Day we have this tradition in my house. And we do this really nice formal sit-down dinner in the dining room. That's the room of the house that never gets used, except for a couple times a year. So we have, it looks super elegant. I mean, it looks like a fancy restaurant. And it's all decorated, and there's, stuff on the table like glitter and balloons, and it looks super swanky. And we usually have lobster, shrimp, and crab legs. And we've been doing this for years, right? And then, my wife and I have wine or champagne, and the kids have like the bubbly, sparkly stuff, and they're in their fancy dresses and all that. Well, one year, my daughter says, as she's eating, she's like, I'm super itchy. And I'm like, oh, no. And we gave her a little Benadryl and kind of blew it off. And then it was a couple of months later, we're at a Chinese restaurant. And she was eating a soup that had seafood in it. And it was the same type of response, but it was really, really much worse. That's what clued me in was, wait a second, it was really close together. And my kids don't really have any allergies, so it's kind of weird. But that's how we discovered it. So there was a sensitization that took place the first time that she was exposed to it. And then there's a memory response. Remember the memory response that happens immediate? And that's what it was. It was like, poof. Right? It was like, she started eating this seafood soup, and it was like, poof! We're like, whoa! This is not good. Okay? Fortunately, I actually did have Benadryl in the car. I don't know why, I just did. But I ran out, got some Benadryl, and everything was fine. But that's the sensitization that takes place. Okay? It's difficult to control once it's started. Right? Now, why does Benadryl work? So let's talk about that a little bit. Benadryl is what? It's an antihistamine. What does that word mean to you? It blocks histamine, right? With an IgE response, right, it's a histamine release that causes all of the vascular changes. And so if you give a Benadryl or an antihistamine, you block that histamine release. Okay, that's why it works so effectively. So it's difficult to control once it's started. The trigger is inappropriate, meaning it's not supposed to be that strong. These are all characteristics of hypersensitivity. So normally you'd want to be sensitized to an antigen, which would be sort of the concept of vaccinations that we talked about in the last minute. But you don't want to be overly sensitized or hypersensitized, where your response is inappropriate to what the response really should be. And that's what a hypersensitivity is. The other last thing is it's maintained. It's maintained in an elevated state for this inappropriate amount of time and this inappropriate level. So hypersensitivities are sort of the body's way of responding to some trigger, and it's normally supposed to respond, it's just not supposed to respond that aggressively. So here is a chart of the 4 listed on one slide. Type 1, hypersensitivity, IgE mediated. We say that atopic individuals, these are individuals that produce more IgE than maybe, quote unquote, a normal individual. Okay, what does that mean? Well, in this room we're all different, and so all of us have different levels of thyroid stimulating hormone. We all have different levels of growth hormone, of insulin-like growth factor. We have different levels of estrogen and testosterone. And those levels cycle at slightly different times in our lifetime. Some individuals hit puberty early. Other individuals are what we call late bloomers. So there's just evidence that there's a variation in our population. We also have people, like in this classroom, that are considered individuals that produce higher levels of IgE than what we would consider normal. And they're considered atopic. Now, they would be more sensitized or more likely to be developing an IgE-mediated type 1 hypersensitivity. IgE is the lowest concentration of all the immunoglobulins in the body, and it does mediate the responses to allergic reactions as well as to any reactions associated with like a parasite infection. Now, type 2 and 3 are very similar, but here's how they're different. Type 2 is a antibody-mediated, where you've got an IgE or an IgM, and that antibody is going to bind to an antigen on a cell surface, or it's going to bind to an antigen in a tissue bed. And one of our classic examples of a type 2 mediated hypersensitivity is blood transfusions, and when you give the wrong type of blood. So on the red blood cell, on the erythrocyte, we have these antigens. We call one antigen type A, another antigen type B. Okay, and so you can either express antigen A or antigen B, or antigen A and B, or you could express neither, and you'd be considered type what? O, or like the null type, is what that stands for. So if you give a type A person type B blood, they're going to react towards the B antigen because it's not something that they're used to seeing. And they will actually specifically go target those B antigen red blood cells and destroy them. Signal them for lysis or phagocytosis and get rid of them. And that's why we actually have the blood type. Now there's another surface marker on the surface of a red blood cell, and it's called the rhesus factor. And so you either express it or you don't. So if you express this factor, you're considered Rh positive, and if you don't, you're considered Rh negative, right? And it's not as strong of a response as the A or AB, A or B or AB, but there is a response. And so we do try to match blood as carefully as possible, but for that reason, the O negative is the universal what? Donor, because it doesn't express either of those three antigens, and anybody can receive that blood. Okay? So if you're an O negative, you are a universal donor, and you're probably called on a regular basis, I'm guessing. Okay? Type 3, this one is an immune complex. So the difference here is the antibody finds the antigen in circulation, not on a cell or in a tissue. It finds the antibody, or the antibody finds the antigen in circulation, and then that moves around the body, and it gets stuck somewhere. Usually, we're going to find that complex of the antigen and the antibody getting stuck in areas of the body where there's perfusion or filtration taking place. And we'll talk about that specifically, like we have it in the vascular space, we have it in the joints, and we have it in the kidney, or in the glomerulus. Because that complex is floating in the blood, and when there's a filter that it can get lodged in, that's where it's actually going to reside. Some examples here are things that we'll look at a little bit later in the lecture, like systemic lupus erythematosus, SLE. The last one is T cell. So the first three are B cell mediated, 1, 2, 3. That'd be a good fact to write down. And the last one, type 4, is T cell mediated. This is considered delayed hypersensitivity because it takes a little bit longer time for it to actually kick in. The examples here would be like type 1 diabetes and transplant rejection that we talked about before. So we're going to walk through each one of these here in a second. There's a question.
Yeah. Would antihistamines like Benadryl only be effective against type 1 or
Yeah.
arthritis?
Yeah, they're really only effective against type 1 because that's a sort of a histamine-related response, and so that's where your antihistamines actually act.
So it wouldn't help with any types of arthritis, or?
Not really, not really. Usually with a lot of the arthritis, you're going to look at anti-inflammatories,
Okay.
or you might get more aggressive with like a corticosteroid, but it's an anti-inflammatory. That's what it's trying to do. With what kind of drugs? Can you treat arthritis with biogeneric drugs? I mean, yeah, there's different types of arthritis. So what we're going to talk about today is reactive and rheumatoid. And then there's osteoarthritis as well, which is where it's just rubbing. Okay. So the difference is like if it's an immune reaction, where it's reactive or rheumatoid, it's usually going to be bilateral. Right? It's gonna happen on both sides of the body because you're developing an immune response, and it's targeting everywhere. It doesn't show up just on one side. Osteoarthritis is a wear and tear, where, like long-term athletes will get osteoarthritis in the dominant throwing arm or something like that, because that's the arm where the bone's starting to erode itself, and they don't get it on their non-dominant side because that's not having that kind of erosion. If it was a immune-mediated response, not a rubbing like osteoarthritis, then you get it on both sides. So like the gnarly finger thing that you see, that's rheumatoid arthritis. That's an immune response. Okay, and that can happen at a very young age. It doesn't. I mean, we see it in elderly population at advanced stages, but I do know that there are. I've even had students in my classroom, that have had juvenile onset of rheumatoid arthritis, and their fingers aren't like that because it hasn't been going on that long. Oh, why is epinephrine so effective for type 1? Yeah, so the Benadryl is kind of an easy response, quick. The epinephrine, stimulating the sympathetic nervous system, quenches that histamine release. Okay, so that's why these EpiPens, like we carry an EpiPen for my daughter now because of her shellfish allergy. And if the Benadryl's not working, then you deliver the EpiPen and you get into the circulation quickly, and it does a very similar thing, but it's more aggressive. Okay, and then the challenge there is then you have to get the patient to the not the operator, the emergency department, because now the side effects of epinephrine are what? Racing heart rate, right? Respirations go up. They're going to be like all juiced up, and you want to make sure that I mean that's a 9-year-old with soda, chocolate and epi on board. I mean, that's dangerous. That's like a menace to society. So you got to get them into the emergency department quickly. Okay, so let's talk about each one of these sequentially. Type 1, IgE mediated. This is our allergens family. Allergies. There's a sensitization process that we talked about. So there's an initial first response, and then there's a memory secondary response, just like we learned in the last unit. So that's sort of our bridge between the last unit material and this material. And then it proceeds on to B cell and T helper cells, CD4, activation. And then you involve these mast cells, and the mast cells are the ones that are going to be dumping out all sorts of chemical mediators. So here is a diagram over here on the right. And you can see here's the allergen, like a pollen. And it's being exposed to the mucosal lining, let's say in the nose. It's absorbed into the tissue and into the body. And it's found now by a B cell. And that B cell becomes activated to be releasing IgE. And that's what we know B cells do. So this is all from Unit 1. And this IgE that's being released now can circulate around and find these mast cells, bind to the mast cells, and you see the mast cell has these sort of granular freckles inside of the cytoplasm. Those are lysosomes that are containing different types of cytokines. And one of the large contents that they manufacture and contain is histamine. And so that mast cell fuses with the membrane surface and dumps the vasoactive amine, like histamine, with a bunch of other cytokines. And you get this immediate hypersensitivity, which is minutes after the exposure, and you also get this late phase, which is even 2 to 8 hours after the exposure. Right? So if you're allergic to cats, you walk into a room, a lot of individuals say, when I walk into a house, I can tell if they have cats in the first 5 minutes. You're like, what does that feel like? Well, I know what that feels like because I'm allergic to cats. Okay? And it's like, well, this red light goes off, in the corner of your eye, because your eye is like red now. Okay? And then the other side does it, and then it's super puffy, right? You look like you gained all this weight in your face. Okay? And then you're itchy all over, okay? And then you just have to leave. It's really fun. So this is the immediate response. But you also know that when you walk out the front door, of their house, it's not over, is it? So 2 to 8 hours later, you're like, why did I go over there? You're still asking yourself because you're still dealing with these effects. So this is the process by which we have type 1 mediated hypersensitivity. On the second exposure, what's different about the first versus the second? Well, the main differences on the second exposure is that the allergen binds to 2 IgEs, right? So you get this dumping of the contents much quicker on the second exposure. Much, much quicker. So you get degranulation, which is the dumping of the contents, and then you also get production, de novo synthesis, that's production from scratch, of these vasoactive substances. And let's look at some of these that actually get manufactured, because I guarantee you some of these are going to be familiar to you. So this blow-up picture is basically what's going on right here. Okay, so if we take that and we blow that up, you can see in better resolution that the lysosome, the vesicle, has these little purple dots inside of it. And here's one where it's fused, here's another one, it's dumping its contents. Well, the granule content, see the first suspect on the list is histamine. And that's what we've been kind of hammering home is histamine. Well, there's other things that are being dumped out too. Histamine just tends to be one of the big ones. Proteases, right? So those proteases are going to help facilitate this really aggressive inflammatory response. And those proteases kind of degrade even some of the extracellular matrix. And it chews up some of that matrix, causing tissue damage even, at some small microscopic level. You have chemotactic factors. The chemotactic factors are there so that you can recruit cells to the tissue out of the bloodstream, right, for an inflammatory response. And if you think about what has anybody ever had like an allergy test where it seems like medieval torture, right? It hasn't changed in like 30 years. They have you take your shirt off, you lay down, and they like stab you in the back with like this grid pattern, and then they put different allergens in the scratches, right? And they're like, ooh, look at that! You lit up like a Christmas tree, like, and then you just feel. Have you ever had this happen? So that's how they do this. They lay you down. They put these little scratches, these small little scratches on your back, and then they drop into it an allergen. And they'll put like milkweed or olive tree pollen. They'll put like pet dander, right? They'll spit in one. I swear to God. I mean, it just seems so terrible. It seems like there should be like, can I just give you some blood? You can put it in a machine and tell me what I'm allergic to? No, they have to do it this way. Okay? So if you've ever seen, I've had students that have had it done and they send me pictures of their back. I'm like, oh man, that's so nasty. Well, it's inflamed. It's like red and inflamed. And that's tissue damage, right? That's what's going on right here. Now look at this. We also trigger this secondary response to start producing from scratch, de novo synthesis, things that come from the phospholipid bilayer using the intermediate of arachidonic acid. You guys remember this? Oh yeah. Okay, so look at here. So now the arachidonic acid creates prostaglandins and leukotrienes, and you've got some immediate responses that take place as a result of your histamine being dumped, like vasodilation, vascular leakage, and smooth muscle spasm. And then you have these late factors being manufactured by your prostaglandin and your leukotrienes, and that's what happens 2 to 8 hours later. So that's why as soon as you leave the room with the cat, it's not like it stops, because you're actually manufacturing from arachidonic acid some of your late mediators to give you this feeling and suffering for hours to come. Isn't that wonderful? So why? Well, remember, this is a normal process, but you're just hypersensitive to the antigen. It's not supposed to be this aggressive. But if it was a foreign material, you would want to respond to it. You just don't want to respond to it this aggressively, and that's why we call it hypersensitivity. So what are the clinical manifestations? Most of the symptoms are due to vasoactive amines. So things like pruritus or itching, bronchospasm, that's a spasm of the airways. Laryngospasm, again, of the back of the throat. Edema, tissue fluid buildup from the inflammation. Redness of the eyes, or conjunctivis. Rhinitis, a runny nose. Hypotension, right? In an extreme situation, hypotension, where blood pressure can actually go down because you're vasodilating so much. Okay? And even gastrointestinal cramps. The cellular infiltration that comes into the tissue is what causes that tissue damage, usually due to a macrophage response. And then there's mucus hypersecretion that takes place as well. So you have constricting of the airways and an excess of mucus production. Both of these in combination can be dangerous, where this mucus is being triggered to upregulate via release of interleukin-13. Where does that come from? That's one of those cytokines that's dumped out of the mast cell along with histamine. So what does this look like in sort of an extreme example? I'm going to dim the lights just for effect. So this is an example of a type 1 hypersensitivity. This is a view down the throat of the larynx. And this is, the top image is a normal larynx, so you can actually see the vocal folds right here. And this is an individual that had a response to penicillin. So the anaphylactic reaction to penicillin in the bottom image is acute laryngeal edema. And you can see how small the opening is now. And if that continues, that airway will close off completely. And the patient could die. And that's why nowadays we're almost hypersensitive to hypersensitivities, right? I had a peanut butter and jelly sandwich for lunch today. Half of one. Because there's a peanut butter and jelly sandwich sitting on the island. It looked perfectly good. So, and everyone's running around. This is about the volume of my house in the morning. Ah! Okay, everybody's screaming, running around, slamming pancakes, and eggs are flying all over the place. And there's this perfectly good peanut butter and jelly sandwich, and I'm packing my lunch. He's like, who's peanut butter? I asked like 10 times, who's peanut butter and jelly sandwich is it? Well, it was my daughter's. She said, today we're eating lunch in the classroom, and we have a kid with a nut allergy, so I'm not allowed to pack it. I was like, oh, sweet. Boom, it's my lunch. Okay? So we're very, very sensitive. Why? Because this is what can happen for that kid. Okay? And we don't know if it's going to be that every time, but we play it safe. And that's why we're very, very cautious nowadays. And you're seeing sort of hypersensitivity to hypersensitivities. So anaphylaxis is this large body-wide response that takes place. And this could be due to a food allergy, environmental allergies like pollen that we talked about, wasp or a bee sting, or drugs, certain types of medications like penicillin, for example, in this particular case. Okay, moving on to type 2. So type 2 is one of the first... Yes, questions, sorry, before we go.
Really quick, can you describe the symptom of hypersensitivity, I think, and maybe pronounce it?
Itching.
Just like sharing?
Yeah.
Okay.
So, Pyrutis is itching, so P-R-U-I-T-I-T-S. Itching.
I kept spelling it wrong, so we couldn't tell my
Can continuous exposure to an allergen like pet dander cause permanent damage?
So the question is, could routine or chronic exposure to a certain type of allergen cause long-term damage? So technically the answer is maybe. And the reason I say that is, what we've learned now is, and you're going to see this play out throughout the semester, if you have chronic inflammation in any tissue, then you increase the risk of potentially mutating that tissue. And if that tissue mutates at the level of the DNA, then it could start growing mass without regulation or checkpoints, and that's considered cancer. And so, for example, the very beginning of the semester, we talked about Barrett esophagus. Remember that? In the Barrett esophagus, I hope you do, because there was a question on the exam about it. The Barrett esophagus scenario is gastroesophageal reflux disease. And so now you've got this acid lining in the esophagus that's not ready or designed for that. And so you get this metaplastic response where it changes, starts making goblet cells, and coats it. Well, if it doesn't stop there, and it continues to grow new tissue at a higher rate because of the damage, then, and if the DNA in that tissue becomes mutated, now you start becoming at risk for developing an adenocarcinoma within the esophagus. And it's due to that inflammation. We see the same thing with chronic asthmatics. So if you have asthma and it's unmanaged, meaning that you always have a basal level of wheezing, and you go and see your primary care physician or your asthma and allergy doc, they're going to tell you that long-term unmanaged asthma puts you in a higher risk category of developing lung cancer. So there are examples that lead us to believe that you should try to minimize inflammatory chronic exposure, and that would be one case. So most allergists will tell you, maybe think about getting a pet that is a non-allergenic pet, right? There are certain breeds of animals that don't have as many of the antigens associated with them as the routine pets. Okay. So it's not proof, I guess, to answer your question. It's more circumstantial evidence that leads us to believe it's probably not good wisdom to say, oh, it's no problem. It's better to say there might be an issue there long term, just so you're aware, kind of a thing. Okay. So type 2. So shifting gears to type 2. Type 2 is our first of two kind of antibody families that bind to antigens that are found within the body, versus type 1 is usually with something external. Does that make sense? So type 2 is usually tissue specific. You're going to find an antigen on a specific tissue or a specific cell. And you produce IgG and IgM. The example that we used in the introduction was blood cell transfusions. The antigen is found on or in the cell itself, and then you make antibodies that bind to that particular antigen. You form a complex in that location. There's kind of three examples that I want to show here that can take place with respect to the heart. So, for example, if you have a streptococcal infection, usually the route of transmission might be strep throat. And so there's an immune response that's generated. And even if you don't go see the doctor with strep throat, you will probably get better. It just may take you a long time. Okay? And that's why when we get strep, we usually go to the doctor and we go get a course of antibiotics, and then the strep throat period of time of being contagious is actually minimized, and then you get over it much faster, right? And not always is the case, but a lot of people think, okay, well, say and if you've got these like pockets on the back of your throat, on the tonsils, those little pustules are usually a good indication that you might have a streptococcal infection, but not always, just so you know. So they'll swab it and they grow it out and see if it's strep positive. That's what they do. Well, this makes it way to a lymph node, the streptococcal, right? It gets into the bloodstream at some level, makes it to a lymph node, and the B lymphocyte sees the strep bacteria and develops antibodies to it. And then the antibodies actually circulate in the bloodstream, and they bind in sort of a non-specific but cross-reactivity to different tissues. Okay? And this is the basis of one type of type 2 hypersensitivity. So, for example, in the heart, when this happens, we see three manifestations. You either get these little vegetations that start forming, you get these Ashkoff bodies, which are regions of fibrous scarring. If it's on the pericardial surface, you're going to get a sort of inflammatory response of pericarditis on the pericardial surface. If we look histologically at the middle one on the heart tissue, this is the Ashkoff bodies. So a lot of times this is a side effect or a result of patients that have had an infection like rheumatic fever. So rheumatic fever is an inflammatory disease that happens after a strep infection. And in the old days, it was referred to as scarlet fever. You ever read in these old books or watched these old movies? Nobody dies of scarlet fever anymore, okay? Because when our throat's a little itchy, we go see the doctor and we usually get a script, okay? So we don't really deal with this much anymore. Although that brings up a whole other topic of, are we overprescribing antibiotics? And are we developing superbugs that are resistant? We probably are. There's evidence to suggest that we are. So scarlet issues may come back. But anyways, this is believed to be this cross-reactivity of the antibody to certain tissue antigens that are found within, say, the heart, for example. And so you get these areas of inflammation that show up as a result of the antibody reacting in a non-specific way. This is all myocardium, cardiac myocardium, and this is the scar tissue that's formed in that little lesion. And this would be a classic type 2 example of hypersensitivity. Now, there are some other ones that I want to show you too. This isn't the only one. But what are the possible outcomes of this type 2 hypersensitivity? Well, these should be some familiar slides, these next two, because we talked about these. The first one is we may actually opsonize and trigger that particular cell or a component of that cell for phagocytosis. So this is an antibody-mediated opsonization, and the cell itself becomes engulfed to be destroyed. Secondarily, a second outcome, like what we're seeing with the Ashkoff bodies in the myocardium, is the stimulation of an inflammatory response. So we've got our antibody mediated with complement present, stimulating the recruitment of inflammatory mediators to the tissue. And now that you've finished and completed Unit 1 of this class, you can think about all the different responses that would take place in an inflammation-mediated response if you're trying to encourage and recruit first responders or neutrophils, second responders are who? Macrophages. And you're going into the tissue to kill or clean up debris that's a result of some signal. And what's that signal in this Ashkoff body formation? The signal is the antibody binding non-specifically to your own tissue. So it's a hypersensitivity because it's not supposed to do that. Is it supposed to bind to strep? Yes. That's why you originally made it. But it actually cross-reacts with other tissue in the body and forms this lesion. Now, there's two other examples that are under this type 2 that I want to characterize. And they're both shown on this particular slide. So this is antibody-mediated cellular dysfunction, where you develop an antibody to a tissue that shouldn't be there because you're hypersensitive to it. So in the case here of Graves' disease, which is this first picture on the left, you create antibodies that are stimulatory, and they recognize the thyroid-stimulating receptor. The thyroid-stimulating hormone receptor doesn't see the thyroid stimulating hormone. It's seeing the antibody, but the antibody, in so binding, triggers the production of thyroid hormones. And that's considered Graves' disease. And we're going to learn about more details of Graves' disease as we move into some of the endocrine disorders. But if you overproduce thyroid hormone, this is called hyperthyroidism. Right? Does that make sense? So hyperthyroidism means that the patient is going to have an elevated basal metabolic rate. They're going to have higher heart rate. They're going to lose weight. They're going to have all the symptoms of overactive thyroid because they're manufacturing artificially too much thyroid hormone as a result of this antibody against the thyroid stimulating receptor. Okay, that's Graves' disease. The second example that's shown on the bottom right is myasthenia gravis. So in myasthenia gravis, this is the neuromuscular junction. You guys remember this from 201? So you've got the nerve coming down, it ends in this little end button, okay, or this synaptic knob. And these vesicles here contain the neurotransmitter known as acetylcholine, and that fuses with the membrane and dumps out the contents when the action potential reaches the presynaptic terminal. And then it's supposed to find the acetylcholine receptor on the postsynaptic side, which is on the muscle, and then that propagates the signal downstream and you get muscle contraction. Well, in myasthenia gravis, which literally translates from the Greek myasthenia, which is muscle, and gravis in Latin means weakness, you develop antibodies to the acetylcholine receptor that are blocking antibodies. And now what happens is the acetylcholine is released into the cleft, but it cannot find, because it's competitively inhibited, it cannot find a receptor to bind to, and these patients with myasthenia gravis have muscle weakness. So they have trouble contracting, muscle atrophy, and thinning of the muscle overall. Okay? So two additional examples of type 2 hypersensitivity. This one is an old example from 201. This is a new example. We might have talked about it in 202, but we will definitely cover it in our endocrine dysfunction. Yeah?
I thought when B cells were maturing, they were tested for cross-reactivity with your own tissue.
Yes, they are, but
that doesn't apply to like a pathogen that's new, or?
oh, no, it does. But remember, if it's leaky, that's a really good question. So wait a second. So here's the question, right? Say the question again. That's a really good question.
Your body tests maturing B cells for cross-reactivity to make sure that they don't react with your own tissue.
And that mechanism's called what?
Oh, I don't remember.
Sounds like enteral tolerance. Central tolerance, nice job. So smart. Central tolerance. So I thought, she said, wait a second. Talking about all this bad stuff, I thought we'd check with central tolerance about cross-reactivity. The answer is yes. And remember, it was some fact, I can't remember it now, but it was like 90%. Wasn't it 90% we signal for apoptosis and we only use like 10% of them? Well, there's only a central tolerance mechanism. There's no peripheral tolerance checkpoints, right? And so if the immune system is leaky, you end up with an allergy, a hypersensitivity. Make sense? That's where it comes from. You're absolutely correct. So, all things being equal, if it was working perfectly, we would not see any of these. Okay? We wouldn't see a type 1. There would be no allergies on Earth. Right? Okay? There would be no problem with blood transfusions. Right? There would be no issues with myasthenia gravis or, well, blood transfusions is different because it's somebody else. So that's not true. That's a hypersensitivity to an other person's blood. So that would still exist. That's not true. But we wouldn't have allergies really per se because we wouldn't be hypersensitive to those types of things. We would regulate that. We definitely wouldn't see myasthenia gravis and we wouldn't see Graves' disease. But this is when it's not working correctly. So that's why, the reason I paused for a moment is it's a perfect question because if you first don't understand how it works, it's really hard to understand how, when it goes wrong, fits in. But now that you know how it works and where it becomes, we use the terminology leaky. If the immune system is leaky and it's not completely accurate, then you're going to get cross-reactivity happening when it's not supposed to, and you get your hypersensitivities. Okay? So almost all of the examples are going to fall into this question that was just asked. 1, 2, 3, and 4. Almost all of them. Not all of them, but mostly all of them. Transplant rejection is an example where it wouldn't be affected because it's not really designed where I'm supposed to get your kidney kind of thing. And blood transfusions, again, I'm supposed to make my own blood. I'm not supposed to react to my own blood, and it's fine. I'm supposed to react to yours if it's got the wrong antigens. But some of these other things, like myasthenia gravis and Graves' disease, would not exist if it was perfect. Okay? Questions?
Just
Yeah.
for clarification, is hyperthyroidism also known as thyrotoxicosis?
Mhm.
Okay.
Yep, we'll talk about that. So the question was, hyperthyroidism, is it also referred to as thyrotoxicosis? And that is true. That's another terminology for it. Yes?
So it's sort of why we're seeing so much associated with T cells, we don't have that.
Yeah, that's why you see sort of more heavy on the B hypersensitivities than you do on the T. But don't worry, there's plenty of T examples.
I'm just curious.
Yeah.
That
Okay.
extra checkpoint helps.
Yep. The extra checkpoint does help, but obviously it's still not perfect. Okay? Alright, so type 3. Type 3 is where you form what we call a median complex. The median complex, what this means is you get an antigen finding an antibody, or an antibody finding an antigen, and then it circulates in the bloodstream and it gets stuck somewhere. It gets lodged. Okay? And so you get this deposition of this median complex. Why does it deposit? Because the complex forms in the bloodstream and then it finds a location to actually reside. And so you can see right here in these pictures, here is our classic Y antibody finding antigen in the circulation, right, forming a complex. And in this case, this complex gets stuck or lodged in the wall of the blood vessel. And then you harbor this hypersensitivity response sort of in the wall of the blood vessel, and this is known as vasculitis. Okay? But we see it not just in blood vessels, we see it in the kidneys and we see it in joints. And in this whole process, you're going to be activating complement because complement is floating in the bloodstream, so it's readily available. And it helps to facilitate the inflammatory response. That's what we learned about in the last unit. So the manifestations that take place with this is based upon the tissue that it's found in. Now, these aren't all of the examples. These are just some examples. So, for example, if it's at the level of the kidney, it's going to be glomerulonephritis. If it's in a joint, it's arthritis. This type of arthritis is known as reactive arthritis, which is a type 3. Rheumatoid arthritis is different. Rheumatoid arthritis is a type 4 because it involves T cells. This is a reactive because it's B cell mediated. And then our example of vasculitis that we just talked about. So our last example, and we're going to take a break, as we're perusing all of the categories, is type 4. So we've just left the 3 antibody-focused ones, and now we're in the 4th example, which is a type 4 hypersensitivity, but it's T cell mediated. It can either be helper T cells or cytotoxic T cells. So it can either be CD8 cytotoxic or CD4 helper. Some examples of T cell mediated responses are things like type 1 diabetes, obviously rheumatoid arthritis that we just talked about, or transplant rejection. Now there are some other ones, but these are kind of the classic ones that we usually think about. And it's often delayed because it takes time. It involves, in this example, this delayed hypersensitivity, which is another word for type 4 hypersensitivity. You can see that this antigen-presenting cell, using the CD4 helper T cell pathway to trigger the release of cytokines to cause inflammation to damage the tissue. Or it could be T cell mediated with CD8s, which are cytotoxic T lymphocytes. Again, these triggering through a very specific apoptotic mechanism to cause cell killing directly. So we could use in type 4 hypersensitivity either helper T cells and stimulate inflammation, or CD8 cytotoxic T lymphocytes to trigger cytolysis. Some other examples. Crohn's disease. Okay, it's classified as a type of inflammatory bowel disease. Contact dermatitis. This is a term for the skin reaction, dermatitis, that's a result of exposures to certain types of allergens that trigger a inflammation response using helper T cells. Well, because it's using helper T cells to trigger inflammation. Okay, it's not necessarily antibodies in this particular example. Okay, so that's a great question. The contact dermatitis is using T cells instead of B cells. Whereas, like if you're allergic to Bermuda grass and it rubs on your skin, you get inflammation. It's because there's a IgE release. This one is helper T cells. Okay. Multiple sclerosis. So MS is an inflammatory disease of the fatty myelin sheath around the axon that you've probably heard of in the past. Diabetes mellitus type 1, or type 1 diabetes mellitus. And then in that example, with type 1 diabetes mellitus, it's our T cells that target our beta islet cells in the pancreas and kill them off. And it's a CD8-mediated response. Okay? And it may kill them off slowly over time. It may not kill them off all of a sudden. Right? So I always get the question, well, I had a friend that wasn't diagnosed as being type 1 diabetic until they were like 19 years old. What's up with that? But we thought it was type 2, but you know, they're very thin, they're very in shape, they don't have a lot of the classic comorbidities associated with type 2 diabetes. They say it's type 1, what's going on? Well, the delay of killing off the beta islet cells could take years. And so there's probably some point where the population of beta islet cells stop manufacturing enough functional insulin now that patient becomes symptomatic. And it could take 19 years, 25 years. It does happen. Okay? Question with that?
Like the type 1, I've gotten like a lot of answers where they say someone had like a cold or something like a virus and then the immune system and fighting that off end up attacking the islet cells as well. How does that work?
Well, so a lot of times it's just shock to the system or trauma. So if you imagine that the beta islet cells are essentially under attack by your own immune system, but it's a slow attack, and then the body has some sort of shock event, whether it's a massive infection, a big cold, a massive flu, okay? In some cases, patients have, and we actually have a family friend who, he was 19 years old, he was a basketball player, and he was kind of away at school, and they went to the fair, and he had like 3 funnel cakes and like 2 things of cotton candy, and he started feeling really sick and passed out. His friends called 911. They brought him in. He had blood glucose levels of 850. And he was classic basketball player morphology, tall, thin, athletic, and the best that we can come up with was there was such a shock to the system of that much sugar in one dose that normally, you know, when he was hanging out with mom and dad, you know, he would have just a little bit of dessert, not necessarily, you know, 3 funnel cakes and 2 things of cotton candy, and that's what pushed him over into this category of needing insulin on a more regular basis. But it could be a flu, it could be mono, it could be some virus or bacterial infection in the patient, and it's just enough to weaken the system where it becomes compromised, and that's the Achilles heel, and then the patient becomes symptomatic after that point. Okay? But it doesn't have to be that. It could just be, it was a regular diet, you know, they're still living at home, eating, you know, very healthy, and all of a sudden they started developing symptoms. It's just, you know, as the beta islet cells die, and then the clinical manifestations start to show up, and at that crossing point is when that tipping point tends to be. Okay? So that seems to be a very real thing, I guess is my point, is the answer that you're getting does seem to show up anecdotally. A lot of these, not necessarily adult incidents of diabetes, but it's not juvenile incident of diabetes, which is what our classic thought process has always been about type 1. And now we're seeing more of an adult onset of type 1 diabetes. We're asking this question, why? The last one is Hashimoto's, and then we're going to take a break. So Hashimoto disease is an interesting disease. This one is when T cells destroy the thyroid. And so instead of hyperthyroidism, this is hypo. So Hashimoto's is a hypothyroid. These patients will gain weight, If they're children with Hashimoto's, they actually may have delayed development. Right? It's not uncommon for these children with Hashimoto's and a underproducing thyroid to hit puberty much later in life. They don't lose baby teeth until much later. They don't lose their first baby teeth until they're 10 or 11 years of age, okay, which is about 5 years delayed. So that's Hashimoto's. And again, that's a T-cell involvement. Okay, so let's take a break and then we'll come back and pick it up right here.